this event on the sidelines of the World Health Assembly. It's called Soft War, Geopolitics and Financing at the WHO. I'm Kim Nguyen. I'm the co-director with Suri Moon of the Global Health Center, and you will meet our distinguished panel one by one, and the biographies are on our website, ghplatform.org. We'll be hearing from everyone on this panel in turn, and we'll have a Q&A. We'll start with Ilona, who will set the stage, and then we'll have Laurence, who will give us a historical perspective, and Joseph, who will speak to financing at the WHO, and Keith Krauser, the director of the Center on Conflict, Development, and Peace, will, and professor here, colleague here, fellow Canadian, will give some discussion of the two presentations, and then my colleague Daniela Moric will moderate a discussion which will last about 30 minutes, and afterwards there's a reception, and I am told with wine upstairs. So without further ado, I will hand over the podium to Daniela, and I will try not to break a leg coming down from the stage.
Thank you, Vinkim. You've made it very easy for me, because I was going to introduce all the speakers, but you just did that. So I think that we're just going to move forward with the discussion, and I'll invite Ilona to take the podium for setting the stage. Thank you.
Well, thank you very much, and thanks for coming to this discussion. And as you heard, in preparation for the meetings that the Global Health Center is planning to do on occasion of this World Health Assembly, we realized the importance of history. And so that's at the back of our discussion, because so much of the changes that are going on also depend on understanding context and history. We're at a time that in German we call Zwischenzeit, and that is the time in between. And I think we're in the time in between orders, while a new geopolitical order is being created. And this new geopolitical order is interfacing in ways that we never imagined with the creation of a new technological order. And therefore, we see very clearly that something that was created, a global health order and, of course, a post-war order driven by US hegemony, is no longer functioning. And this challenges us not only to worry about what is happening now that there is less money in the system or something like that, but really to start imagining what comes after the crises and how do we get through the crises. Because of course, you know, this interfaces with many crises, with the crises of multilateralism, as many people say, and of course a crisis of what we might call the suborders, driven by that same hegemony, and that of course is the global health order. So obviously we want to look forward and say what comes after. And in our discussions, Vinkim and I have frequently spoken about, you know, after global health. And in order, as I've indicated, to think forward, we do also need to look back. Our focus to some extent is the WHO, and I'm really intrigued that as I talk with many people about the WHO, that they have rather little knowledge of its history and definitely very little knowledge of its political history. And this is, of course, where we want to pick up. I just want to take three short examples that we tend to forget. When something happens, we always think it's the first time. And very frequently it isn't. So my first example is the first withdrawal of a country or set of countries from the WHO. And this, of course, happened right after the founding of WHO in 1949, when the Soviet Union, together with several other so-called Eastern Bloc countries at the time, objected to, you guessed it, Western dominance, and decided to leave the organization. It's very worthwhile to look at the discussions and also to the solutions at the time, because the then Director General, a Canadian, came up with the idea, oops, we could let membership rest. And so that was the solution that was taken. And what did one wait for? One waited for the death of Stalin, also a medical event. And then the USSR and its partners came back in full. So you can see that threats can be dealt with differently, also political threats, if you are creative in how you handle it. My second example is one that has had, significant impact right in the way that we run global health today. And that is, the first major budgetary and political crises of the WHO, which happened, would you be surprised, with a conservative American president. So the Reagan administration criticized the WHO that it is ideological, anti-corporate, and politicized. And it criticized this because of the Alma-Ata Declaration and the concept of primary healthcare, the ideas around essential medicines list, and various issues of that nature. And you will recognize the arguments: overstepping technical mandates, hostile to free markets, and too little accountability and effectiveness. How often have we heard that in the last 20-odd years? But the thing I want to underline is the long-term consequences of some of these actions. Because with this, what happened, it set the stage for decades of financial strain and laid the basis for the donor-driven influence on WHO and on global health, because it led to the zero growth policy that was adopted in 1983 by the member states. Actually very worrying that the member states adopted this. And that, of course, meant that WHO's regular budget could not increase. And you know everything that follows. It was also the begin of the neoliberal time, a neoliberal turn in global health. And I won't go through any great detail here, but we live with those consequences until today. And it's actually that concept of global health that is now being questioned and is falling apart. The third example, just to hint at it closely, is the trust crises. The trust crises in relation to WHOs have been very linked to infectious disease crises. And you just take three examples: the swine flu, where WHO was criticized for overreacting. Then you had the Ebola crises, where WHO was criticized for underreacting. And then you had COVID, where WHO has basically been approved of doing everything wrong. And probably coming here, you've been passed by wonderful blue buses that are telling you not to agree to the pandemic treaty. But these external disease crises have put WHO in the public arena in a way it never was before, in the political arena, and linked, of course, with the growth of social media and the technological world that I've indicated. So just to keep that in mind, that as organizations continue, they continue to carry the burden of what has happened before, and they need to understand what has happened to be able to address a new world. So the world now is different, obviously. The WHO needs to be different. We heard a little bit about that yesterday. And we need new changes, but we need changes of a different type. And we need to see what they are, because think of the Reagan changes, whether the next round of changes is going to be as consequential for such a long period. I see very little analyses on the WHO and global health governance that actually shows this thread from the zero growth budget through to what we are experiencing today. We know that the hegemony is gone, and that this would actually be the opportunity to create an organization that can really take up the challenges of the 21st century. But, and this is what the Global Health Center has started working on, is to also fundamentally reflect how we will redefine global health, which of the many definitions that are out there actually hold. Do any of them hold? Definitely a development-driven global health paradigm cannot hold. A neoliberal paradigm should not hold. A global public goods paradigm is something that people are discussing, but that we're not there yet. And therefore, what we will need to do is, particularly in academia where we are, is to contribute to redefining what global health is, and through that also helping shape the new global health order. Thank you.
Thank you very much, Ilona, for starting our conversation and for laying out the key issues so clearly. I would like now to invite the second speaker, Professor Laurence Monet, for the second presentation, and we are going to have slides, so the floor is yours.
Thank you so much, Daniela. Good afternoon, and thank you very much for this introduction. I will go back to a few points that you were making, Ilona. I'm a medical historian, and the first thing I want to talk about is what the past tells us. First of all, that the WHO has faced multiple crises since its inception. Second, these crises have been of political, economic, epidemiological nature, or even all of this at once. Third, it is important to remember those past crises, or better, to entrust their history to professional historians who can reveal their nature, their determinants, their effects, in short, both their complexity and their potential. I'm being optimistic here. Let me take one example that has been mentioned earlier, the one of USSR inactivity in WHO from 1948 till 1959. According to several global health historians, and I'm not one of them, the crisis has led to constructive scientific competition, to regional health cooperation, to reflection on the US post-World War II technical assistance approach, to fruitful discussion about primary health and what primary health care could mean, drawing from earlier initiatives in social medicine and rural hygiene in Europe, Latin America, and Southeast Asia in the interwar period. In sum, this complex crisis led both to the successful smallpox eradication campaign and to the signature of the Alma-Ata Declaration in 1978. So what historians of health are telling you is that crises are inevitable, they are recurrent, and they are opportunities. They constitute opportunities to debate, to be creative, to reform, and also, and I won't talk about that because it could take me for ages, to recycle, to do better with this. Today, the fact that future transfer of US funding to the WHO is on hold, while there is a pandemic agreement draft on the table, and while we are in a measles pandemic, is, I think, an extraordinary opportunity. To put it differently, these interconnected crises could lead to much-needed discussions about the past, the present, and future of vertical programs and techno-solutionism in global health. Let me take a couple of minutes to illustrate my point. And I'd like to focus on the global elimination of measles, which is once again being promoted as measles cases are, once again, dangerously rising around the world. Why am I taking this illustration, this example? It's because I've been working on a global history of measles for several years, and this is what I do know now. Since the early 1960s, the US have been working to eradicate the measles virus. This goal was first set at the national level when it was estimated that measles was too costly for the national healthcare system, causing too many complications and hospitalization, and for the US economy as a whole, at a time when US women were entering the workforce. Local eradication of measles, as we called it, the national elimination at the time, was discussed as early as 1962 as the first measles vaccines were developed, or actually were developing. Despite recurring local outbreaks of the disease and the difficulty of increasing vaccination rates nationwide, the goal of measles elimination gained ground in the Americas region in the 1980s under US leadership. The WHO was very skeptical for a long time, but the global health imperative in the early 20th century overcame this reservation, supporting the return to the forefront of vertical programs and the expansion of vaccine-based solutionism, driven by more and more private actors at a time of new infectious and pandemic threats. A measles elimination plan in steps at the national, regional, then global level was then structured. Despite its limitation and its sometimes unexpected and problematic consequences, for instance, the process of national elimination certification leads to extremely costly epidemiological surveillance and undue competition between countries seeking to obtain the certification, as well as strong stigmatization of unvaccinated individuals and groups. It is difficult today, beside these problems, it is difficult today in public health and global health circles to conceive measles other than as a vaccine-preventable disease that must be eradicated at all costs. As a result, there is a strong focus on vaccine refusal and vaccine hesitancy. On the eve of the COVID-19 pandemic in 2019, the WHO declared that vaccine hesitancy had become one of the 10 major threats to global health. I'm not saying that vaccine hesitancy doesn't exist, and I'm not saying that vaccine hesitancy is not problematic in the fight against measles, which is highly contagious and requires extremely high vaccination rate. What I want to emphasize is that the quest for global measles elimination reinforces the focus on vaccination-related issues at the expense of other critical issues, including access to quality basic health services for children in both the global south and the global north at a time of huge challenges to national healthcare system. The quest for measles global elimination also prevents us from considering the multiple factors at work in the virus's relentless resurgences. Among the factors responsible for these resurgences and the omnipresence of the viral disease in several countries in the global south are poverty, the extreme mobility of vulnerable population, and malnutrition. These factors actually have long been known to lead to infection and its spread, and they are factors that need to be addressed more efficiently in order to improve the health of as many children as possible. While some countries are considering introducing a third dose of measles vaccines into their immunization schedules, and why some experts are calling for new, better, more effective vaccines that are going to be inevitably extremely costly, What the historian is saying, what I am saying, is that the global elimination of measles is both an ideology and a business, and that the elimination imperative is in need of urgent discussion in light of the history of the viral disease management and its limits. How can we be more ambitious in addressing measles as a global issue? How can we address the risks that measles poses, not only in terms of leaky borders, suboptimal immunizations rate, and ignorant anti-vaxxers, but also in terms of unequal access to basic healthcare and living conditions? The US not being at the table for the moment could actually make the space needed to raise again these questions, to explore and evaluate other possibilities to control the disease like measles more adequately, more fairly, and in a less costly manner. It is, in sum, a great opportunity. I'll end this brief talk by stating this. First of all, understanding historical processes is key to respond to crisis adequately, even if it takes a lot of time. I've been working on global history of measles for decades. The goal of eradicating vaccine-preventable diseases such as measles, or the priority given to pandemic preparedness in global health, are the result of complex histories that need to be unpacked. The interconnected crisis we are currently facing, one of many, could actually be an opportunity to bring interdisciplinary work, social scientists and historians to the table more systematically and make better, fairer, more sustainable decisions in global health. And before thanking you for your attention, I would like to remind you that data are disappearing all over the US, at the CDC, at the archives in the USAID organization, and that historians like myself need these data, the archives, to be kept safe and to care for. And I thank you for your attention.
Thank you. Thank you. Thank you, Laurence. I'm sure we're going to come back to some of the key points that you made during the discussion. Before I call Joe to join us at the podium, just a reminder that at the end of the presentation, you will be able to ask questions. If you are in the room, a microphone will circulate, but if you are joining us online, please type your question in the chat box, and we have an iPad, and we're going to monitor the chat. We're going to see your question and ask them directly on your behalf to the speakers when we're going to open for Q&A. And now, Joe, maybe your turn, if you can join us at the lectern for a second presentation.
Great, and thanks. It's nice to be here, and thank you for the invitation. I'm not an expert on geopolitics. I'm not a historian also, although my first degree was in history, so I'm happy to be on sharing the stage with a historian. So I'm an economist who worked for nearly 30 years in WHO, in headquarters, regional level, at country level, and I'm going to try to give the perspective of how these things play out internally and how the organization works a bit, and only an angle on it, because it's much more complex than what I will describe. So first, I'll give a quick overview of how WHO is funded and why that has been a source of concern, picking up on some things that Leona said, and some reflections really on how this plays out, particularly from, since I'm an economist, I'll talk about some of the incentives arising from this. For today, there's also a concept in economics called principal agent theory, where you have, in this case, the principals, or whose objectives you're trying to support, are really the member states, right? And the agents are the secretariat in an international organization like WHO. There's a nice paper on this using WHO as an example from 2014. And the idea of this theory is, of course, it's based on a simplistic assumption that there's unity amongst the principals and there's unity amongst the agents. And in fact, that's not the case in reality, that you have diversity of interests in both cases. And while that's often been recognized, of course, amongst member states, it's perhaps less well recognized about how this plays out within a bureaucracy as well. And I think that's an important thing to recognize. So on the financing of WHO, and again, just to go quickly over some of the things that Iona shared, initially the idea was, like any UN agency, to be funded from assessed contributions, which are driven by a formula that is largely based on GDP and population and so on. There was some initial supplementation from, in early days, from the 60s, from some voluntary sources. And those grew over time to the point still where the voluntary comprised a quarter of the total funding of WHO by 1971. Continued to grow, especially, I think, in part, especially in later years due to the HIV epidemic as well, that this was driving a lot of things. So by the mid to late 80s, it was about 50-50. And as Iona said, you have this then zero real growth policy. That kind of applied to the assessed contributions, but the voluntary kept growing as well, because that was still the case. So the budget of WHO, in fact, did keep growing. And even then, and I'll say in the mid-1990s, so 30 years ago, people were writing about some of the concerns of this. As you heard, that while priorities are meant to be driven through the normal governance processes at headquarters and regional level, through the assembly, through regional committees, there's a real question of who's actually driving the priorities when so much is coming from these voluntary things. There was as well, again, referring back, I think, to what Iona was saying about some of the parallel reporting processes from particular donors, growing fragmentation, and this unpredictability, in fact, of what would happen with donor funding. In many ways, when I was looking at this for WHO, it's very much a parallel of what happens with development assistance in countries, right? That, the idea you can't necessarily rely on the donors, they won't be there forever, so you need to start changing and transitioning now. Okay, so we'll come back to that parallel in a moment. More recently, and I'm showing this just as a kind of offer of congratulations in a way to WHO, because about, I guess, 10 years ago, maybe it was a little more recently, they developed this open budget portal, which was a response to criticism about financial transparency. So they put it online, and basically on this site, which hopefully if that's available to everyone, you can find basically the sources of funds, how it flows, and ultimately at the end to which priorities it flows. So it's really kind of a goldmine of information that goes back to about 10 years, to the 2016-17 budgetary period. What we can see, and really it's been holding steady over the last 10 years, the dark color of this bar chart is the share of WHO revenues that comes in highly specified form, mostly through that specified voluntary contributions. The green is the flexible part, which is coming through the assessed contributions, the UN formula, plus some additional funding that some governments have decided to give to WHO in a very flexible way. So in fact, it's a much more serious issue than it was 20 or 30 years ago, that despite the warnings of the concerns, you have this problem. A critical point, and we'll come to this especially with the US withdrawal, is that WHO implements on the basis of commitments, not on the basis of cash in hand. So much of the money committed for this biennium, for 24-25, has already been spent before it has arrived, okay? What's critical here in terms of the changes happening in WHO now is really that about 2/3 historically of the flexible money, the green part, was going to salaries, because not every program was equally effective at raising money from donors for its priorities, right? So you have the salary money in green, and that's being squeezed, especially with the non-fulfillment of the commitment by the US. So in a way, with all of this flexible money, or much of it going to salaries, the ability for the organization to actually direct resources to priorities is constrained. Now that's one way of looking at it. Another way, and I was using the portal to look at how polio is funded as one example, because when I started looking at the portal, I was surprised at just what a high share of all of WHO expenditure goes to polio control, okay? And it's almost 20%, and this was in 2018-19, so before the pandemic, effectively. It was that year, or that biennium was showing about 18% of WHO spending, but in fact, most of that spending was driven by 4 funders, only one of which is actually a member state. Okay, so Gates Foundation, Rotary Club, I had to look up what the National Philanthropic Trust was. I didn't know what that was, but they're an important funder of WHO's work. So I'm not here to say that this is right or wrong in terms of what should be the priority of WHO, but the question to be raised is, did this skew the priorities? You know, because we don't know, could that money have been used for other purposes, or would it have not come at all? Okay, but it is a legitimate question to ask, by what process was this priority set? And I think that's the concern in terms of how it was determined that such a large share of WHO's resources would be for this. Sorry, yeah. So I want to come now to a bit of how I experienced, and not a lot of it. I used to write I was kind of the complainer in chief among the staff at WHO, so I'm not going to go through all of that, but basically to reflect a bit on some of the ways that this type of financing the organization intersects with the multiplicity of actors that are in place, and part of which I was guilty of too, for some of the problems that I will note. It was noted again that basically those problems really haven't gone away. To some extent have become more entrenched. And when you think about the funding and the not real growth of the voluntary unspecified, of the mandatory unspecified funding, it was clear, and certainly I felt this as a manager, that I can't do much with just the regular budget, that I have to give a lot more attention to fundraising and nurturing relationships with donors or my partners in donor agencies. And there was a lot of parallel reporting that had to take place. I will say, and I give one positive example here, that it's not the case that the staff or the organization was kind of a passive, participant in this. There was a lot of efforts by programs, by funders as well, to try to consolidate certain things. And there are good examples like the one here to kind of align the donor reporting process with each other, first of all, when there's multiple donors, and also with the standard normal process through the assembly. But I don't know how exceptional that is. It has happened, but that's a concern. The other is, I used to always say that WHO is a faith-based organization in the sense that basically just go ahead. Even if you don't have money now, it will come. And it worked very well. If you think of the voluntary contributions, the donor money not being predictable over time, you still grow. As a manager, your incentive is to still grow your program because you know that the DG or your regional director will bail you out. And it has worked for most of the time I've been there. It works very well, except when it doesn't. And it didn't when I first was just coming back to headquarters at the end of around 2010-11. There was a big financial crisis and a lot of cutbacks of staff. And this was following the global financial crisis, donor funds coming back. And those programs that had grown on the soft money now were facing cutbacks, right? So it's kind of like it's good until collectively it doesn't. And then some serious changes were needed. So again, as was said historically and as Iona was saying as well, some of what we're seeing is not new. The other part has to do with the internal fragmentation in the organization of various departments and programs and so on, and whether that's a problem. In my normal work in health financing, we would always advise countries, you want to pool all of your funds at the highest level possible, ideally a national level pool, so that you can redistribute to where the needs are. But when I'm sitting in a bureaucracy, I have a different rule, which is basically that funds should be pooled at the level that I manage, right? Because I need that certainty in a way to allow me to go forward. So if I'm the director general or a regional director, of course I want the highest level of flexibility possible, right? But if I'm a program manager in the organization, then I want money for my program. Everybody else's thing should be flexible as long as I get mine, in a way. So this is kind of the concern in terms of this. And it's kind of like being in a hospital where the head of the hospital, the CEO, might think they're in charge, but there's all these doctors heading the different departments, and they're driving resource allocation and their status and priorities and so on. So WHO has a bit of that structure, that there's a lot of entrepreneurial behavior because there has to be. That's how we survive. And in a way, I don't think it's a problem of bad intent. I think it's a problem arising from the fact that everybody is really committed to their agenda and what you want, which is that somebody working on a particular area, whether it's my area or somebody else's, thinks that that's really important and are fully committed to this, so they're going to do it. But it leads to problems in how things work. I'll give one example of how this played out, which was a case not exactly in Malawi, but I was approached by a deputy minister of health from Malawi at a conference who said, we're trying to do a proposal to the Global Fund for funding. We want to use our integrated national health plan, but the Global Fund says, no, you have to do separate disease-specific plans. So we're like, well, what is the Global Fund doing? So I asked my team, who's here right now, to engage with the Global Fund, find out what's going on, and she calls the person and he says, look, we're just following WHO's advice. And it turns out that was right, that basically one part of WHO is promoting this integrated approach to primary health care, and that's kind of what they're supposed to be doing. But another part is focusing on their diseases, and that's what they're supposed to do. And critically, they report to different ADGs, Assistant Director Generals, and different funders. And as long as nobody takes charge of that and recognizes that as a problem, that continues, okay? So just some last thoughts on what I think might be at least tentative in some directions for WHO. I think it's saying here low-income countries and WHO. I'd say low and middle, some middle-income countries. And on the graph here is basically showing the extent for low-income countries in purple of how much of their health spending comes from external sources, from donor spending. On average in low-income countries, it's about 30%, but you see a big variation in there. But the idea is we and others have been working with countries for some time to kind of prepare for this transitional process and so on, and the idea that it should be done over time, and not much was really done, okay, in fact. And now instead of doing a change over 5 years, you've got 3 weeks to make this change. And as Laurence was saying, we also need to see this as an opportunity. I mean, I was talking to people in South Africa who said, this is going to be hard, but we're so glad to be rid of PEPFAR. And that will, we will make it work, right? Now, whether they will remains to be seen, but that's a country issue. For WHO as well, it's harder because WHO doesn't generate its own resources. And just to say that it's a very real crisis, right? So this chart is basically, for the current biennium, when you look at the assessed contributions, right, the mandatory contributions, the share that should be coming from each country is according to what has been agreed. So in the US, it's almost a quarter, and it's not coming, which means that that money, remember, has already been spent, a lot of it in 2024 and some of it in 2025. Now it's a big hole that has to be filled. So while it may have been 2/3 of that money before going to salaries, now it has to be a lot more from the other sources, okay? And so there's really going to be a severe situation. My understanding is I know there's an attempt to address this and to kind of accommodate, but there's no getting out of this without a lot of pain for people. And it's not just staff, it's also content of the work. So I guess my message here is that, it's going to be difficult. It's painful. It's going to have real human cost, but we still need change. And I think this is kind of a core message that despite, in a way, what the need for change is not justified by what the US government has done. And the US government is not suddenly giving, by doing this, it's not saying, oh, we should have realized now we need to do this, right? They can both be true in a sense that there needs to be a way to change how global health works. That doesn't mean accepting the forces that are driving what's happening now. So the last thing I'll say in terms of comments for WHO and building a little bit on the example I was giving is that there needs to be more than cosmetic change. And some of this is recognizing that there's a difference between cutting expenditure and improving efficiency, right? That these are not the same and they shouldn't be seen as the same. And also that a new organogram is not reform, right? It can help. A new organogram alone doesn't change anything if you don't change the underlying engineering and incentives in the organization. So again, in my example, that if you're deciding that PHC is the orientation we take, then you have to align things behind that and resolve these potential conflicts, right? Between the disease approach and the more integrated approach and so on, and find a way to consistently move. The second point, which I think is really important, and I've noticed, and it relates a bit to this, is that there needs to be a distinction between the functions the organization does and how money flows. So for example, if what might be called the normative function, like developing new disease guidelines for whatever TB or child health treatment, it makes sense that the program in headquarters in particular develops those, right, and promulgates those things. That's a very different objective from improving child health in Nepal or Malawi, right? In which case, you don't give that resource. It's not the job of the headquarters program on child health to do that, or even the regional or country program, because it may be those problems are caused by lack of nurses or inadequate access to care or other things for which the specific program may only have one part to play. And right now, the organization has one process for both functions, in a sense. So I think this needs to be addressed. And the bigger point around all of this is that when programs are reporting to different, basically assistant director generals or different directors and regional level, can't let that fester. Somebody has to take charge of that and say, this is the direction we're moving, and we have to align behind that. Thanks.
Thank you, Joe. Excellent presentation, raising some fundamental questions regarding WHO financing. Now, actually, we are done with presentations. We're going to start the discussion. And first of all, we're going to hear from Professor Kraus as a discussant. We're going to hear some reflection and some responses to the key points raised by our presenters. Professor Kraus, you have the floor. Thank you very much.
Thank you for this. These were two quite rich and divergent presentations in certain ways. And I'm coming at this from outside of the global health community, but as someone who works in parallel with development, humanitarian, and peace and security networks. I would echo Ilona that there's really no doubt we're in a transformational moment, but I think it's also one in which it's by definition impossible to actually see your way clearly to the future patterns. This is a little bit like Gramsci's line that the old order is dying, the new is yet to be born, and a whole lot of morbid symptoms appear. And we are seeing many morbid symptoms in our daily headlines. So I want to just pick on a couple of threads that were mentioned by the two speakers here. The first is that this isn't just about budget cuts and about the transfer of funding from assessed contributions to voluntary contributions. And it's not comparable to previous crises, for example, with the USSR withdrawing, as it were, or being silent. I think it's actually a broader crisis. And from a political science point of view, and I hesitate to say geopolitics, but geopolitics is everywhere, we are in a period where the stability that was provided by the hegemon has disappeared, right? And oddly enough, there is something we call hegemonic stability theory. And it depends on the ability or desire of key states or state to provide the global public good without a transactional approach to the costs and benefits that come with that. In other words, looking towards what are the overall benefits, are everybody's boat rising, are things being distributed in a way that may not be equal for everyone, but is increasing the shares of all in some respects. And this is characteristic not just of the way in which we think about global public health, but about economics, about peace security, about development policy in general. And this paradigm is over, as it were. The development aid paradigm, the donor paradigm has ended. The idea that there is a hegemon that is willing to play the role of providing stability for the system, I think is over. And therefore we have a global public goods problem in all domains, not just in global public health, but in environment, in climate specifically, in the global economy and elsewhere. So obviously we need to look a little bit beyond, and I'm not going to dive into the organizational weeds because I think that was really important, but I want to focus on something slightly different here. We need to look beyond the Trump administration and the US and the 22% loss of budget in at least two ways. First off, as the Secretary General has acknowledged, many parts, if not most, of the global multilateral system are broken. And an organization chart is not a policy, I think is paraphrasing you, and yet that is what has emerged from the UN Secretariat, at least, which is how let's reorganize into 3 or 4 baskets, let's rationalize, let's simplify. That itself is not going to solve the problem because that's an internally focused mechanism or an internally focused idea when the real challenges are somewhat outside. There is no alternative hegemon that is going to step in. There is no strong coalition, and the reason we know that is because assessed contributions are not going up. Voluntary contributions are becoming more disparate and issue-focused, and so we don't have a consensus even among the alternate states, and I don't see China stepping in to be the alternate provider of public goods or anyone else. And when people say we're now into a transactional or a broadly transactional era, we should take that seriously because they're going to be calculating the costs and benefits of particular policies in a very narrow, self-interested way. That's clear from the Trump administration's focus on dismantling USAID and rethinking its foreign policy, but it's also true in Sweden, it's true in the Netherlands, it's true in various other countries around the world. And in public health, costs and benefits mean choices about who lives and who dies. And these are going to be made based on very narrow calculations that are quite distant from the humanitarian impulses that have governed at least part of global public health. I'm not going to pretend that it was always a humanitarian enterprise. It was not. Its origins before the 20th century go back to keeping diseases out of the industrial world from the so-called tropical areas where all sorts of bad things came. And it was also an imperial project. That's very well understood by historians. But there was a strong humanitarian thread that went with it, and that's being shredded in some ways in all domains, not just public health. But the second thing, looking beyond the US, is that we have to look inside. There are people protesting with 4 buses and a bunch of colorful balloons out there. And I did try and Google a little bit about what they're all on about. But they're very issue-focused, relatively conservative, and they're reflective of anti-global, anti-vaccine, anti-science, anti-elite, anti-big pharma, or even maybe anti-global corporations movements within many of the core Western states that did provide some contribution to these global public goods. And so if we don't know what's happening within many of the core Western states and societies towards a commitment to public health, I mean, measles eradication is not a global issue only in the South, as it were. It's an issue in parts of Canada, parts of Switzerland, parts of elsewhere, and it's going backwards in several important ways. At least I think you would. Maybe it's not going backwards. Okay, you're an optimist. Your presentation said you were an optimist. I'm a pessimist or a realist.
I don't predict the future.
Yeah, I don't either.
It's about predicting the past.
Yeah, we're good at doing that. So I do think that this thinking about what the transactional world means for actually how people are going to, what costs and benefits they're going to calculate, whose costs and who gets the benefits, is going to be important on this. I'm just going to close with a couple of things borrowing from a colleague of mine who works on peace building here. We're going to have to be very careful to think about the critical functions that need to be looked at in all organizations. What do we protect? What are the core functions? What do we adapt? And where do we have to innovate? And they have to go together. We cannot just protect and adapt. There has to be innovation along the way. And I'm not the expert in public health. I think that's for all of you to decide. But we've clearly lost a lot of time looking at your charts, the point we reached today was probably fairly predictable. Not the how and the why, and the earthquake is never quite known when it's going to occur. But the fact that we were going to be faced with this situation, it shouldn't be news to any of us. And we have some responsibility for the fact that we didn't start responding to it 5 or 10 years ago. Thank you.
Thank you. Thank you very much for this very thought-provoking intervention. I'm now very happy to open the floor for questions. I have a colleague who is around with the microphone. If you want to ask a question, please raise your hand. I see one question up there. I'll take a few of them, so please, if you have other questions, raise your hands. And also, we are checking the chat online. And if you can introduce yourself and also telling us who are you addressing your question to.
Yes, hello. I'm Andrew Harmer. I'm an academic at Queen Mary's University in London. I have two very brief questions. One is to Professor Krauss. It's an IR question. I'm wondering why the other 193 states, why should they do something that just one other member state is deciding to do? Just because it's transactional, the other member states don't have to agree to behave in the same way. So why are they going along with him? The other question is a global health question, financing. I don't understand why the amount of money that we're talking about is tiny. It's a really small amount of money. So I don't understand why the other member states are not just chipping in a bit more. I mean, if we just paid $3 million each, the problem would be resolved. So why aren't they doing it?
Thank you. Is there any other question? I see one up there, two up there. Oh, please.
Yes, hi. Thank you so much for the presentation. It was really interesting. My name is Juhi. I'm a student of global health at the Geneva Graduate Institute. And my question was, how do we really incentivize private funders to start investing and fill the gap that the US has now created in global health? And is there a need to then reposition or repackage health as a security issue now? Thank you.
Thank you. I'm taking the third question. Thank you.
Okay. Thank you. My name is Jacques Madère. I'm an independent and retired. My question is about the future. You alluded in 2 speeches about the possibility to put global public good in the center. What would it need to progress on this agenda, which is, for me, quite promising? Thank you.
Thank you very much. So we're going to start the first round. Maybe I can group the question on finance for Joe. The first one, the money, well, it's a tiny sum. Why don't they pitch in, the rest of the countries? And also maybe the role of the private funders for Joe, or whoever else wants to jump in.
Well, I mean, I'm pretty sure the reason that member states aren't putting in more is not because we haven't asked them, right? I mean, it's not a financial question. You're right. I mean, some people have looked at like the whole budget of WHO is like one hospital system in New York or something like that. I mean, I think that I mean, I don't know with the others because this is much more of a political question, right? Is what is preventing that decision from happening? And clearly a little bit related to the question on private funding of WHO, for example, there is a lot of private funding of WHO in the form of these private foundations and so on, but it's highly specified, right? So that's one issue. The other, I think for global health more generally, and I don't know how the others feel, is that there is also, you know, in the sense, especially in like in the medicines and technology area, there's a lot of, you know, private investment in that, but governments have done not a very good job of capturing, you know, of reflecting the fact that there's also a lot of public investment and there's been a lot of privatization of those benefits in a way. I think the concern with trying to get more private money into WHO is it doesn't address the core problem of, specified versus other, apart from all of the other kind of accountability issues, right? I mean, it's obviously not through a member state process. And I don't know if it's too late or what the others think, but the idea, there's been this, and maybe it is really since the Reagan and Thatcher era, this idea of the privatization of public responsibility. More generally, if I can get a little philosophical, has been going on. How to reorient away from that, I think, is something that is, again, beyond the health sector, but something we need to be thinking about. So that was a long way to not answer either question, sorry.
Great, anybody who wants to answer the question, I'm just kidding. But maybe we can hear from this side about...
193? Well, I mean, the 193 at least continued to negotiate the pandemic agreement and are trying to take it forward. So there is an ambivalence there. They have been discussing for 5 years to increase the assessed contributions, very much pushed by 1 or 2 countries, including mine. But I think one of the reasons that stands in the way, aside from, not generally wanting to give more money to multilateral organizations, et cetera, is that it has become incredibly unclear what they get from the World Health Organization. And that's where I want to, underline what Joe has said, and that we heard that yesterday, those of you that could be here, that while, this move forward to have a more consolidated organization, to have, a clearer management structure, et cetera, is at present only the first step, because the second step is for the Secretariat to clarify what are we really going to do in the next 10 years, and then for the member states to agree to that. And as far as the transactional stuff goes, you see, I don't think anymore that the currency is life saved. And I think the currency for WHO as a normative organization should never have been life saved. It's, really establishing an order for global health. And it's in this order that transactional thinking is now entering. Transactional thinking, geopolitics, if you give me your vaccines, I'll give you something else. If you give me your minerals that I need to produce vaccines, I'll give you access to my supply chains. It's about innovation, who will share which knowledge with whom. And science has become so much more important. I mean, WHO's always said, we're evidence-based. But, science has changed in a way that's just unbelievable. And all this is mixed up with what I said, the new technological order and the role, for example, that data play in general, data play in health, and that WHO no longer has the resources or the technology to actually deliver to countries what is one of its most basic functions, and that is, what does the health of the world look like? And let alone in terms of pandemics then, to be able to do that in real time. And of course, for that, it needs money. So the context of the transaction then also is a different type of transaction that takes power into account. Now, which transaction will lead, to the rise and fall of the pandemic agreement? That's access and benefit sharing. And that's, the other side of the world saying, hey guys, yes, let's be transactional. We'll give you a genetic sequence and you'll give us 20% of your products. So yes, transaction is happening, but in quite a different way. And I don't think we've yet fully captured that change of thinking, that change of culture, and also what defines global health. And I think COVID did teach us what defines global health. It's access, it's equity, it's supply chains, it's all kinds of stuff, and a lot of stuff, like you said, that's not even in the health system anyhow. But if we just look at that narrower thing, trade, intellectual property, all in a new way that we yet have to garner as part of what we call global health today. And I haven't even talked about climate.
Thank you. Laurence, you wanted to?
Yeah, sure. Sure, because I obviously I agree with what has just been said, but I would like to go back to the question about how do we improve global public good, actually. I think global health should be about local health. And when I'm saying that, I'm going to take two examples, and I'm going back to COVID. During COVID, I was in Montreal, which was one of the, the hottest spots of COVID. And I couldn't travel. I'm a specialist of Southeast Asia, and I was working on history of measles, but because of another infectious disease and a pandemic, I was stuck in my office, and which was a weird feeling. But anyway, I decided to actually help and work with private actors, local philanthropic organization. But so the money was coming from private investors in a way. But what was really interesting is that we were working with local community organization and actors on the ground in the poorest neighborhoods and trying to find a way to deal with the pandemic at the very local level, what people were asking for, what they needed, and what we could do, what we could provide. I could go at length on this illustration. I've worked with them for 18 months. But when I was working, and one of the things we were looking at is how we could improve immunization rates when the campaign began, because in some neighborhoods with a really high rate of COVID cases, people didn't go to the clinic, and the government was like, but they are anti-vax or hesitant, and actually it was not the case. The problem was they had difficulties accessing the clinics and everything. So I was helping, informing about the campaign and accompanying people and so on. And it reminded me of my field work in Cambodia. I'm working in Cambodia and Laos mostly these days, and I used to work in Vietnam 25 years ago. And it was the same thing, like private public actors, in a way, we don't care. That's not the main issue. The main issue is looking at what's happening on the ground at the very local level and asking people what they need. This is basic community health, basic primary health care and community health, from the ground, and doing something about it. And that's not that costly. So I don't think the private-public thing is the most present issue. The most present issue is going back to what actually public health is, community health is, and improving equity, because you're absolutely right. The past is not the present, and it's not the future. But in terms of equity or lack thereof, we have a big problem.
Thank you.
I can be brief and be a little bit provocative to our colleague from Queen Mary. The UK has some catastrophically bad public health outcomes right now. And UK voters may or may not be conscious of that and may or may not vote for that reason. But if you're asking why should they invest money, why don't they spend a little bit more on X, Y, and Z somewhere else, I think that one of the things that's happened in the last 30 years, and you evoked Reagan Thatcher, was massive increases in both inequality between states and inequality within states. And this inequality has driven the rise of populism and the disengagement from any kind of solidarity ethic. And that's what's at the heart of these decisions not to invest elsewhere. Why shouldn't you spend the money 100 kilometers north of Manchester, improving some public health outcomes there? And these are decisions that are difficult to make, but we in the global health community, and we speak casually about creating a global health order or whatever, these terms do not resonate with people's everyday experiences in a lot of the countries where the money comes from. And I think that's one of the bigger challenges. And going local and looking local also means, as you put it, in Montreal, I'm glad you weren't working in Alberta, though, at the time, to make an inside reference on the pandemic.
Thank you. I'm looking at the audience and I see a question here. I'm also looking at Ellen. Is there any question from the chat online? Would you like to take the microphone?
Should I go first?
Maybe we can go first and then we're going to hear from Ellen as well. We're going to take them all together. Please, go ahead.
Thank you. Excellent presentation so far and really good insights. Al-Hadi Usman from Save the Children UK. Really interesting conversation about WHO. I'm just following up also on the Lusaka agenda, which I believe, like also talking about Gavi and Global Fund. So given that the Lusaka agenda calls for more country leadership, health system, and this is really now coming just in time with the tightening budget, not just to WHO, but also to Gavi and the Global Fund. Do you think it's the right time now for WHO to actually change its mandate? And if yes, then should WHO shrink in terms of core responsibilities and core capacities for an organization, maybe given that how it was when in its inception? Or should the WHO maybe focus on actually absorbing some of these other GHIs like Gavi and the Global Fund, UNAIDS? And I see like there are already conversations around these lines to be able to be the organization that's providing comprehensive mandate to serve like universal health coverage globally. Is it time to delegate some of WHO's responsibilities to regional bodies or national bodies, civil society maybe? Just how do you see the future? How do you read the future down the line? Maybe my question is more to Mr. Joseph, but others, please feel free to share your insights and input. Thank you.
Thank you very much. Ellen?
So 2 questions here. Dear all, thank you for the excellent presentations. The accessibility of resources and nationality is connected, and at times of political economic trust crisis, how can WHO strategies involve with people who are refugees and stateless? That's one. Another is, again, thanks for the presentation. The issue has been beautifully outlined from different angles, but how might we initiate change, and who do you think should lead it? And then a third is actually mine, which is, if I may, because power here, I have the mic. You know, when we think historically, I mean, the global community was only really created out of kind of a sense of crisis catalyzed in the late 80s by the AIDS epidemic, and started in the early 90s. And over the past 30 years, the global community has been phenomenally successful. It has moved 2 billion people out of the worst, most abject forms of poverty. There's a huge amount of work to do. There are still 2 billion people. But things have changed and life expectancy everywhere has increased. We've been really successful, and I think the world has changed so much, and I've worked a lot in WHO, and I didn't always have the sense that programs really reflect and have changed to adapt to the changed nature, economic and social development, and the capacity that many countries have today. I don't have a question, sorry.
No, this is great. Thank you very much. So change. And I really would like to hear all of you on this change. How do we go about it? How do we change mandates? Who should be leading us through this period of change? Maybe I'll start from my left side.
Well, I think to some extent I've already said it. It's of course a very complex political process. It will be, you know, first of all, the responsibility of, if we're talking WHO, the WHO Secretariat itself to come up with something. And I think in the midst of all this, we're going to have in the next 2 years the election of a new Director General. And I think this discussion of what should WHO be and do will be, you know, a leitmotif for that highly political election that's coming along, and that's going to start sooner rather than later in terms of people putting out ideas. I think, I personally think that on the one hand, WHO, I'm very conservative, WHO should go back to its constitution And what we really need at this point is, with all the changes going on, is a normative organization. And while I'm, with you in terms of, what are we doing locally, the fact is, some things won't reach me locally if I don't have a secure supply chain. Some things will be unhealthy if somebody hasn't set the standards for air quality and for food. And I think what we have neglected, collectively neglected, and there I must also be very critical of the NGO world, is to actually bring across why such normative change, why such norms are so incredibly important, and what we must do to take them forward. And here, which is my favorite thing at the time is, it will include new things that WHO needs to do. And I really think one of the key issues at stake at present is the extraction of health data without anybody having any control over that into the technical companies and platforms. And we need an organization that is able, to bring countries and actors together to address 21st century health problems. And because the world has changed so much, by the way, reducing poverty, we wouldn't have done that without China, because most of the figures are the reduction of poverty in China, not the reduction of poverty in Sudan. So I think, we must be very, very specific here, also what our general data show us. And that also applies for many of the health data that we throw around.
Well, I don't know what to say after that, but when I'm talking about the local, of course, it's not at the expense of the global. I think I'm very conservative. I think the WHO has done great things, and we've had international, spaces for discussion for not forever, but at least from the mid-19th centuries, and it works wonders. But I agree also on the fact that, and it's coming back to the local for me, that, poverty and rates like decreasing in terms of poverty and everything, it's Asia. It's not the global community, it's not the WHO per se, it's what's happening in East and Southeast Asia for a big part of it. So I think the thing is we have to decenter the way we look at things. I think that's something we have forgotten about for quite some time, and we have to not go back necessarily. I'm not saying that the past is better, that's not what I'm saying, but in the 1970s and 80s, we were looking at China and what they're doing. We had to for various reasons, but we actually looked. And again, working mostly on Cambodia and Laos this day, I'm personally amazed. I'm doing a lot of field work. I'm working with WHO people on the ground, especially in Phnom Penh. And I'm amazed by the way the country has improved standards of living there. Nobody is talking about it. The way Cambodia dealt with the COVID pandemic, it's one of the, it's almost a flat rate in terms of mortality. They've done a wonderful job. Who is talking about it? No one. So there's something there in terms of, just find a way to look at things differently and mix the global and the local. And I'm not sure about the idea that there's a global community. There are global decisions and initiatives. But locally, and what's happening locally is important. If I go back to the measles elimination thing I was talking about, and I was not talking about Southeast Asia earlier, I was talking about US leadership and ideology when it comes to measles elimination. But on the ground, what you see is people fighting to control measles the best way. It's not about elimination. It's about decreasing the number of young children being sick or dying of it. And what has changed, in the country of Cambodia, is, the higher standards of living. And it's not coming from the global community. Part of it is coming from it, because we all know that Cambodia used to be like the playground for NGOs, since genocide. But still, there's a strong local, national leadership, and it's changing things. And that's what I think we are both saying, is we need international, transnational organization and decisions and data and so on. But we need to include in the discussion, and a critical one, what's happening on the ground. And it's not that I'm not seeing that. I think we should do it more. And by the way, it's less costly than some of the initiatives we were obsessed with, like, you know, eradication and new vaccines, and so that kind of thing.
Thanks. Yeah, I add my endorsement of the previous comments. I think that we have oftentimes in the global things just undervalue that a lot of the positive changes are happening because it's the country responsibility. And in Geneva in particular, we have, you know, I don't mean only WHO, other organizations that like to take credit for lives saved, things, when fundamentally it's the countries that are making the decisions and doing things. So we need to kind of, in a way, it's hard to analyze any agency on its own, independent of how it interacts with the countries. In terms of what WHO should do, I mean, the question about like the global health initiatives and so on, my view from my experience is that WHO is not very good at moving large amounts of money, right? So the idea that WHO would be the new home for the Global Fund or Gavi, and there's two things. One is that that's not what the organization is designed to do. It administratively can't do that very well. But then there's also the, you know, things we see now that actually money flows. Gavi is one of the third or fourth largest funder of WHO, which creates a conflict of interest between the technical role that the vaccination department is supposed to be playing in WHO and the delivery role that the funder is supposed to be supporting. So apart from just WHO wouldn't be very good at it, it's not a good role, and it can in a way compromise the neutrality of the organization, which is a real strength. In my experience, one of the things that I found in a lot of country engagement, and I had a very supportive regional director when I was in the European region, was basically that I would say our strength is that we have no money. So that if they don't like what I have to say, I can take my $5,000 and leave. But the point is that my value to them was the political part of this, right? They want to have WHO endorse their policy because they can use that. And so you don't give that away cheaply. You use that in a sense that you can bargain with it well. So I think that is very important. The one thing, and we haven't responded to everything, I'll just note it, maybe Richard will speak to this, about the issues around refugees and stateless people. I mean, just the design of WHO makes this maybe even more of a problem, right? Because they're not represented by member states in a sense. So I don't know, I mean, others can speak to that more. But in terms of WHO doing the normative and focusing on that, I would say yes, and there's always some wiggle in this because there's a lot of work to translate norms into practice and how far the organization should go versus when it stops and how to kind of engage in that translation. There's a big difference, let's say, in what I did, which is health financing policy, for which there's not a global prescription of here's how to do it, but there are principles and lessons and facilitating exchange of knowledge. So that's one thing. The last thing I'll comment on, because it was never emphasized in the SDGs, and it speaks a little bit to the regional level, but also national level, has to do with institutions. And so, for example, there's like a Africa CDC, right, which is in place, relatively new building. And the idea is how to support regional institutions like that actually take on that role and not substitute for them. So that type of thing. At country level, in my own work in Kyrgyzstan, it was to develop institutions around health policy analysis. Okay, so there's a lot of things that have to be there, and those institutions take time. They're not going to be in place by 2030 with a quantitative measure of them. It doesn't make them any less important. And in a sense, if the country is in the center driving things, then how to play a supportive role so that, in a way, by whatever date, a country is better positioned to make its own decisions using available data and so on. That's kind of, I think, more the aim we want to go towards.
Two things quickly. First, and I didn't answer this, one person asked about whether or not we should treat health as a security issue, and I would put a big "no, don't do that" sign in front of that, because that is exactly what triggers responses that are inward-looking, nationalistic, to some extent focusing on protection of the self, the nation, the body politic, whatever. It's antithetical to any notion of global public goods and an ethic of solidarity. So don't go down that path. Second, I'm not a historian, but I'm going to do that here. The post-1945 multilateral architecture was the outward projection of a particular configuration of power, a high concentration of power that existed in 1945, and a strong consensus among a very small group of states that are now completely unrepresentative of the real world out there. So when you talk about organizations that have to reclaim their normative purpose and so on, I'm going to say whose norms and whose values are going to be reflected in that right now. And that is a really big challenge. The protesters outside think it's their norms and their values, and they're from the UK and Spain and elsewhere, and they're, as near as I can tell, fairly opposed to reproductive health policies and things like that. So there is no consensus on which to build this kind of set of normative foundations to move forward. And what that leads me to is the idea that we're going to be in a very fragmented system, what one of my colleagues has called multiplex, which is not multipolar, but actually multi-actor. There's private actors, there's public actors, there's local NGO actors, there's transnational NGO actors, and there's states. Not always the most important actors in that equation. And there's big money. And so this is, I think, is going to be the environment in which we have to navigate, and we have to get away from any image, and I think you said that well, that is focusing on either a top-down or Geneva-centric or an institutional-centric multilateral system, because that's not the world we're going to be. We are, in fact, that's not the world we're living in.
Yeah, I just wanted to add one thing. Because it's like that, we need organizations that bring these voices together and negotiate. And I do think the negotiations for the pandemic agreement are a very helpful and useful example, because looking back over the last years when there was sort of this sleepy consensus in global health, and also the countries that make up the majority of the population of the world were not as outspoken yet as they have become, also through other organizations like BRICS and G20, et cetera, that I think the negotiations around the pandemic agreement brought these differences to the fore. And if anything, that is why, the not perfect consensus that's discussed today and tomorrow is so important, also historically, because that's the ultimate role organizations like this can play. And sometimes it works and sometimes it doesn't, but nobody else can bring them together. And I think the more fragmented the world is, in a way, the more investment into this kind of bringing together and fighting it out has to be taken forward. And we've not yet found, in a way, also some of the right mechanisms to do that. And again, the sort of role WHO has to initiate discussions, to take things forward, to bring various actors around the table, has to be strengthened again. And for that, that what you said, Joe, has to happen, that it has, while everything's political, a certain air of neutrality, that in a sense, who actually pays us and who do we bring together. So I think the multiplex actually needs a context in which it comes together. And, for the next 5 years, fights like hell for all I care. But at least they're talking, and I do think that's important.
Okay, thank you very much, and I think that with this we have reached the conclusion of our discussion. I would kindly ask you if you can join me in giving a round of applause for our speakers. and thank you also to you for your thought-provoking questions. And now I would like to invite Vinkim for closing remarks.
I'll be very brief. I think something that was indirectly addressed was this question of soft power and how organizations like the WHO were in this post-World War II order used to project a certain form of power, and that now we're in a completely in-between time, and we don't know what exactly is going to emerge. And I think that's something to keep in mind as we watch what and participate in what happens in the next few years. There's a number of theories or critical analyses that invoke terms like techno-feudalism and capitalisme de la finitude, but I'm not going to go there. But there is a sense that everything has changed, that we don't know exactly where we're going, and I think that's come through quite clearly. Another thing which did come out was this, and I want to emphasize, was how unfit for purpose the current global health governance architecture was to respond to that new order. And I think that's just what we see when we have structures that are built on a previous reality. Finally, I wanted to say something about WHO's role as a normative organization. I think what a lot of people don't know is that, so normative sounds like, rules, values, but it's also about interoperability, standards. What does so much grams per deciliter of cholesterol mean? Doses of medicines. So a lot of WHO's initial work was actually making possible the medicine that we take for granted now. And and if we lose that, we really lose everything, basically. So a lot of WHO's early successes, we just don't see it anymore because we take it completely for granted. So I think we have to remember that. It's a very important function that no one else can do. And without it, we're going back to the Middle Ages. No, I don't want to be dramatic, but things like drugs and vaccines and standards for how clean you keep your hospitals, all that will presumably erode. So I will just end by inviting you to join us at the reception upstairs. We have 2 more events, Tuesday and Wednesday, in this room on 2 treaties, the Pandemic Treaty, which you've heard about, and the Plastics Treaty. So look forward to seeing you then. Thank you very much.